Hello everyone, happy evening, a very good evening. A quick note first, whether I'm audible and visible, everyone. Hello everyone, is it fine now? I'm not able to see the live chat, just give me a minute. Low sound, is it still very low? Let me try checking this, give me a minute. Okay, is the sound any better now? Is it better now? Am I audible? I hope the sound is not much now. अभी ऐसा तो नहीं कि बहुत ज़्यादा बढ़ गई आवाज़. I hope I'm audible, well audible now. Okay, that's great. So happy evening, everyone. A very good evening. I hope and I believe all of you are doing well amidst all the chaos that NBEMS is trying to create with so many messages every single day of the centers changing. We really do not know what lies in in future in the next few days for us. Absolutely like unpredictable. And honestly, I'm telling you that if I had the power and I had all the facilities, I would have tried to change it. But unfortunately, I'm yet another mango person like any one of you here. So I think we are in a choiceless state and a helpless state is what I believe. Okay, so what we are going to focus today is all the important images in radiology that is must revise for your exam. So this particular session, first we are focusing on all the radiology images. We will have one more session on a YouTube live for your last minute revision, where particularly we would be revising all the FMG July 24 questions also, because that's going to be a good revision of all 19 subjects. Plus you would also get to know that what questions have been asked in FMG July 24, right? So a one shot revision of all the FMG July 24 questions, or maybe maximum in 2 sessions is what we'll try to do that. I'll update you on that on the Telegram group. Right, what I would suggest is whoever is booking the tickets and flight tickets, especially book the refundable tickets. You never know what lies ahead. Okay, so without wasting any of your time, because I know that it's absolutely precious, so we are going to focus on the revision. I have shared the PDF on the Telegram group, so you can get the PDF from there as well. Okay, so let's start with this. A quick revision. Target is maximum 1 hour, 1 hour 15 minutes में ये finish कर दे. ठीक है? So what are we seeing here? This is a barium swallow image which is done for esophagus, and what do you see is the narrowing, the distal tapering of the esophagus, the bird beak sign. Okay, what are we seeing here is the bird beak sign. So remember the bird beak sign, distal esophagus narrowing, this is seen with Achalasia Cardia. Okay, this is Achalasia Cardia where the LES remains contracted and it does not relax. Okay, so the esophagus proximal is dilated, but this is narrowed bird beak sign. Remember, for Achalasia Cardia versus carcinoma esophagus, how do you differentiate the two? So we are going to learn all these in an integrated fashion with the particular disease also, the important points about that along with the radiology images. Okay, so here in Achalasia Cardia, remember the dysphagia is more to liquids or solids. Remember here the dysphagia is more to liquids, because the solids with their weight will force open the LES, the liquids will not. Okay, so there is dysphagia more to liquids. And what is the gold standard investigation for achalasia? It is manometry. Okay, the gold standard is manometry. And remember that 24-hour pH monitoring is not done for achalasia. pH is related to acid alkali. So remember, it is done for acid reflux, the gastric acid reflux, that is GERD. 24-hour pH monitoring is for GERD. And also remember the trick for achalasia. What classification do we use for achalasia? Remember, CHCH, it is Chicago classification which is used. There is Chicago classification. And HAL helps you to remember what myotomy do we do? Heller's myotomy. Even though it is HE, but to remember it is Heller's myotomy. And another surgery for achalasia is POEM. Peroral endoscopic myotomy is what we do, right? So remember, POEM is also a surgery done for Achalasia Cardia. Which parasite is associated with achalasia, can cause achalasia? Again, remember CH for CH, it is Chagas disease. Chagas disease, Trypanosoma cruzi. I hope the short users know the story of the Chagas disease, Cruise Pay, Tom Cruise, right? Romantic Tom Cruise, that's the story there. Going to next one, next barium swallow images. What do you see here is the corkscrew appearance of the esophagus. Remember, this corkscrew appearance of the esophagus is seen with diffuse esophageal spasm. Logically thinking, esophagus going into spasm diffusely. These are all the contractions that you are seeing. This is diffuse esophageal spasm. The history comes at when the person eats something hot or spicy, there is a chest pain which is felt. Okay, so that is diffuse esophageal spasm. Yeah, you can watch this video later also. This should be available even as a recorded video. So if you want to watch it later, you can do that as well. Okay. Right, going to next one. This is a barium meal. Remember, meal is for stomach. What does the meal go into? Meal goes into the stomach. This is barium meal. This is the pyloric narrowing. Okay, so this is the pylorus which is appearing like a narrow. Anywhere narrowing in radiology is called as string sign. Okay, so this is the string sign of pylorus, IHPS, CHPS, idiopathic or congenital hypertrophic pyloric stenosis. Right. Now remember some important points about CHPS from pediatrics. It presents at what age? It does not present immediately after birth. It is at around 2 to 4 weeks. Right. That's around 1 month. Okay. And remember, the vomiting here is going to be non-bilious because it is stomach obstruction. Right. And when you say this is hypertrophic pyloric stenosis, so it is the stenosis is because of hypertrophy. Hypertrophy of what? Hypertrophy of circular muscle, not the longitudinal muscle. So what is going to be the investigation of choice for this condition? Because I want to prove that this is hypertrophy of the muscle, I can see the muscle on ultrasound without any radiation to the child. And that is why the investigation of choice is ultrasound, important. And how do I prove on ultrasound that this is a hypertrophic pyloric stenosis? With more than 4 millimeters thickness of the muscle layer and more than 16 mm length. Remember, 4 and 4 square. 4 millimeter thickness and 16 millimeter length. So that is how you prove that this is hypertrophic pyloric stenosis. Otherwise, it just goes into pylorospasm. If there are symptoms like pyloric stenosis, but the thickness is not more than 4 mm, then you put it into pylorospasm. Okay. And tell me what drug is associated with development of CHPS in the child? What drug is associated with development of CHPS? It is erythromycin. Okay, that is erythromycin. Okay. Now, what sign are you seeing here on ultrasound? Remember, it gives the inner circle and outer circle. Narrow lumen and the thickened muscle layer. What sign does it give? Remember, that is the target sign or the donut sign. Okay, that is the target or the donut sign that you see here. And what is the correct statement? For CHPS is a medical emergency or a surgical emergency. Remember, this is not a surgical emergency. This is a medical emergency. Okay. The first thing is not going to be surgery. The first thing is going to be fluid and electrolyte correction. So it is not a surgical emergency. It's a medical emergency. Okay. These are the important points. And what surgery do we do for this? Remember the name of the male child. This is common in the first born male child. Ram. Remember, this is Ramsted's pylorotomy. Ramsted's pyloromyotomy. Ramsted's surgery is done for CHPS. Okay. Going on to the next one, very favorite in the recent FMG July 24, instead of this double bubble, triple bubble was asked. So do not be under this impression कि हमेशा exam में double bubble ही आएगा. This is the double bubble, the two air bubbles. Understand the concept that air is black on X-ray and CT. Okay. So this is the double bubble sign, which is seen in the two bubble stomach and duodenum. This is duodenal atresia. What is it associated with? Another D. This is associated with Down syndrome. D. Double bubble, duodenal atresia, Down syndrome. And double bubble can also be seen in annular pancreas. Okay, it can also be seen in annular pancreas, which will try to obstruct the duodenum. Okay, so this is double bubble sign. Okay, double bubble sign. Where will you see the triple bubble? Like we said in the recent FMG, the question was on triple bubble. 1, 2, 3, stomach, duodenum, jejunum. So it is going to be jejunal atresia. Okay, that's going to be jejunal atresia. Right. Going to next one, the image that you see here. What investigation is this? This is the colon with the horstrations that you see. This is the colon. So this is barium enema. Now in the barium enema, this narrowing that you see here in the transverse colon, with the shouldering like appearance here, with the shouldering appearance, this is apple core sign. Okay, what sign is this? This is apple core sign. Remember, core is car. This is seen in carcinoma colon. Apple core, carcinoma colon, carcinoma esophagus. It is suggestive of carcinoma. Next one, this is the coffee bean sign. Okay, this is the coffee bean sign on X-ray for sigmoid volvulus. Okay, this is seen with sigmoid volvulus. When the sigmoid undergoes a twist. So remember, sigmoid volvulus will lead to what obstruction? Small bowel obstruction or large bowel obstruction? जब sigmoid obstruct होगा, sigmoid twist होगा, तो उसके ऊपर आएगा descending colon, transverse colon. It is going to lead to large bowel obstruction. Okay, large bowel obstruction. What sign do you see in barium enema with sigmoid volvulus? You give the barium, it reaches the point of volvulus, and what happens at this point? The barium forms a beak. So that gives the bird beak, or it is also called as bird of prey sign. Okay, bird of prey, looking upwards, a bird. So bird beak or bird of prey appearance. Next one, what are you seeing here is all these are the diverticuli coming from the colon, the outpouchings containing the barium. So this is the sawtooth appearance of colonic diverticulosis. Okay, this is sawtooth appearance of colonic diverticulosis. Remember, diverticulosis means multiple diverticuli present, but they are asymptomatic. And when it becomes symptomatic, there is pain. So that is diverticulitis. So remember, for diverticulosis, the investigation of choice is barium enema, while for diverticulitis, when there is acute inflammation, you do not give barium. So in that case, it will be CECT. In surgery, you must have read what classification is used for diverticulitis. What classification are used? Hensch's classification. Okay, that is Hensch's classification depending on the extent. Okay, depending on the extent. And when there is diverticulitis, where is the pain? In what quadrant of abdomen? LIF, left iliac fossa, because sigmoid colon is the most common site for diverticuli. Okay, sigmoid colon is the most common site. Going to next one, what do you see here is, this is the colon, which is appearing very rigid and a smooth walled colon. There are no horstrations which are present. So this is a smooth, narrow colon with the loss of horstration, which is called as lead pipe colon. Okay, and where do you see lead pipe colon? Ulcerative colitis. Remember, colon and colitis. Toxic megacolon, ulcerative colitis. Lead pipe colon, ulcerative colitis. Okay, so remember, this is lead pipe colon, ulcerative colitis. Next one, what do you see here in intussusception? Remember, the classical history in intussusception will be a child, weaning age group में common है जब lymphoid hyperplasia, Peyer's patches hyperplasia होता है, right? So a child, mother gets a child with the history of red currant jelly stools, that is passing of blood and mucus in the stools, red currant jelly stools. So when there is intussusception, red currant jelly stools, if it is a child, Investigation of choice, if it is a child, it is ultrasound, no radiation preferred. If it is an adult, then CECT is preferred. Okay. And what do you see on X-ray is some ill-defined sausage-shaped mass, that is what it is called. And on ultrasound CT, what do you see is bowel going inside bowel. So inner bowel, outer bowel, right? So what do you get here is inner bowel and outer bowel. So this is called as target or donut sign. Okay, this is called as target or donut sign. Again, which was seen in CHPS, the same thing here, target or donut sign in intussusception. Okay, and what do you see here on barium minimum? Very, very important. So when you give the barium goes up, and when it reaches the point of intussusception, it forms a claw. So remember, this is called as claw sign. And the second one is, if there is some space between the inner and the outer bowel, then you would see the barium outlining the inner bowel like a coiled spring. Okay, so then you get the coiled spring sign. So claw and coiled is intussusception, right? That is intussusception. And what is going to be the management for intussusception? Remember, the management is pneumatic reduction or even hydrostatic reduction is what you can do using the saline. So air enema or saline enema jaise karke you try to reduce the intussusception. So pneumatic reduction, hydrostatic reduction. Going to next one, this is again a very, very important image. So what investigation is this? This is a CT because the bone is white. This is a contrast CT. Can someone tell me what is this structure here on the CT? No. Hydrostatic reduction by just saline, not barium. Tell me what is this structure? Identify anatomically. What is this structure here? Anyone? Is this the gallbladder? Yes. First, identify the structure, anatomy. Is this a gallbladder? See, you have to be very good with your concepts to answer the questions, because remember that concepts are what help you to answer even the new questions. If your concepts are good, remember this is not gallbladder. Logically thinking, tell me that gallbladder contains bile, which is fluid, which is water. So fluid water has what color on CT? Remember, it is grey color. Like you see this, okay, identify this structure here. What is this? The jet black appearance on CT is? What is jet black on CT is air. What is grey on CT is fluid, right? And you can see this rugae of the stomach. So this is the air fluid containing stomach, right? So if it was gallbladder, it should have been this grey color. Okay, and gallbladder is not in front of the vertebra, it's not a posteriorly located, right? It's more anterior and superficially located. So if you look at this one, this is the aorta, and to the right of the aorta, this is going to be the IVC, has been asked in one of your previous exams. So aorta ke right mein hai IVC, and this on the right side, this is the liver. So again in the liver, you are seeing grey color wala lesion which is showing some membrane floating within it. So this is the water lily sign of hydatid cyst. Okay, remember this is the water lily sign of hydatid cyst. Okay, clear with everyone? Going to the next one now. This is an ultrasound, and the classical thing that you see here is, this is the posterior acoustic shadowing. Okay, the posterior acoustic shadowing, so suggestive of gallstones. Look at how the fluid appears on ultrasound. Fluid on ultrasound is black. Okay, fluid on ultrasound is black. So this is the posterior acoustic shadowing suggestive of gallstones. Cholelithiasis. Remember, for gallstones, the investigation of choice is ultrasound. But if it is CBD stone, okay, if it is CBD stone, what is the investigation of choice for CBD stone? It is MRCP. You diagnose it on MRCP, then you remove it on ERCP. ERCP is therapeutic also. Okay. Going to next one, look at this image. What investigation is this? Where you see this gallbladder, this is the CBD. There is no white bone that you see here. There is no endoscope that you see here. So this is MRCP. Okay, what is this investigation? This is MRCP with this lucency in the CBD, telling you that this is CBD stone, choledocholithiasis. Okay, choledocholithiasis. Look at this image here. This is the ultrasound again, but this is a kidney now. The echogenic thing with the shadow behind. So this is the posterior acoustic shadowing of renal stone. Okay, remember, be it gallstone, be it renal stone, be it bone, be it air, all of these can show shadowing. Anything which is a bad conductor of sound will show the shadowing. Okay, fluid is a good conductor of sound. It will not show shadowing. It shows enhancement. But air, calculus, bones, they do not allow the sound to conduct and they will show shadowing. Okay. For renal stones, the investigation of choice is CT because they are calcified stones. But for gallstones, it is ultrasound. Okay. Next one. Now again look at this one. Vertebra hai. Uske aage you can see here. एक grey color fluid density lesion hai with a well defined wall. So this is the pseudocyst. Pseudocyst which is seen in acute pancreatitis. Now definition wise, pseudocyst is seen in what kind of pancreatitis? Non-necrotizing pancreatitis, that is interstitial edematous pancreatitis after 4 weeks. That is when the collection forms this wall and it is called as pseudocyst. Okay, and it is called as pseudocyst. And what is the investigation of choice for acute pancreatitis? It is CECT. Remember, any inflammation, infection, mass, you will do a contrast scan. Okay, so it's a CECT. And what will you see on CECT in acute pancreatitis? Any organ which is acutely inflamed will appear bulky. So you will see bulky pancreas. Again, a previously asked question. Bulky pancreas on CT tells you that this is acute pancreatitis. Atrophic pancreas tells you that it is chronic pancreatitis. Okay, clear with everyone? Right. Going to next one, some emergency radiology images, very, very important. Another question here. Tell me, what do you think is this structure here? Anyone, what do you think is this structure here? Anatomy. Okay, so Shruta, why is that not amoebic liver abscess? Because you see the membrane floating. That is classical of the partially ruptured membranes of Hydatid cyst. Amoebic liver abscess will just be grey. It will not have any membrane floating in that. Hydatid scan is done for biliary tract. Okay, to look for the patency or atresia or the leak from the biliary tract. Chalo, very good. I see someone answering this. Dekho, main jo question पूछ रही हूँ, पहले उसका answer do. What is this structure here? Is this the clavicle? No. Think very logically, guys. Whenever you get questions on radio anatomy, you just have to integrate with your basic anatomy that you know. So in the CT, this is anterior, this is posterior. So this bone that you see is present posterior to the rib cage. This is the rib cage और उसके पीछे जो दिख रहा है bone, rib cage के पीछे कौन सा bone आता है वो होता है scapula. Okay, so this is going to be scapula here. And the three structures that you see here, this is the right side, this is the left side. Remember, in radiology it's opposite. Your right is the patient's left. So from right to left, this is going to be SAP. Remember, SAP आता है right to left से. ठीक है, right to left से आता है SAP. So this is superior vena cava. This is ascending aorta and this is pulmonary artery. So what is this structure here? What is this structure here? So this is descending aorta. So remember that vertebra के बाजू में descending aorta, that's the posterior mediastinum. Ascending aorta is on the anterior mediastinum, right? I've covered the entire radiology from basics, from the concepts, along with all this anatomy, all the pathologies in detail in the Prep Ladder app, right? So for someone who's using or would be using Prep Ladder, please watch those videos, at least a rapid revision, where you would have all the important images being discussed there. Okay? Okay. I'll show you the SMA. I think I have one of the image. I'll show you the SMA there. Okay. So what is the pathology here is, this is a pulmonary artery. This entire thing is a pulmonary artery. This part of pulmonary artery is not filled with contrast. So that means there's a thrombus or embolism sitting here. So what is this here? This is pulmonary embolism. Pulmonary embolism, right? The history given here will be immobilized patient, long travel का history है, recent surgery का history है, पहले calf pain edema था DVT के वजह से, now that DVT has embolized to the pulmonary artery. So this is DVT, इसका source है. So what is going to be the screening test for this? Screening test is going to be D-dimer. Investigation of choice is going to be CTPA, CT pulmonary angio. Screening is D-dimer. Okay. And if CT pulmonary angio is not in the options, you have NCCT, CECT, go for CECT. CT pulmonary angio is nothing but the contrast CT. Okay, so it's a contrast CT, right? And what criteria we use for pulmonary embolism? Wells criteria. Okay, remember there is Wells criteria which is used. No, Jen, this is not how it is. Remember, be it CT, ultrasound, MRI, it is ulta. Your right, जो आपका right है वो patient का left है और जो आपका left है वो patient का right है. ठीक है? Aorta is present on the left side, not on the right side, until and unless it is that norm variant which is there. Otherwise, aorta is present on the left side. ठीक है? Okay, another question here. Guys, tell me what structure is this one? This has been asked in one of the previous FMG exam. What is this? Yes, waiting for the answers. What do you think is the structure here? Right. So remember that this is a bronchus, this is not the esophagus. A normal esophagus is a collapsed esophagus. It does not contain so much of air, right? So this is the jet black air containing bronchus. This is left bronchus, and what do you have here is the right bronchus. Okay, so that's the right bronchus, left bronchus. यहाँ पे कहीं आएगा esophagus. ठीक है, collapsed structure. Going to next one, very very favorite, recent FMG exam में भी आया है, the black air under diaphragm. So air under diaphragm, this is pneumoperitoneum, which is because of the hollow viscous rupture, right? That is bowel perforation basically. Okay, bowel perforation, pneumoperitoneum. So remember that in pneumoperitoneum, where there is bowel perforation, barium is contraindicated. Okay, barium is contraindicated. So what will you use here? You will use iodinated contrast. Most commonly being used is iohexol. Okay, if iohexol is not in the option, one of the previous exams, the option given was gastrographin. Okay, that was gastrographin. Okay, so this is pneumoperitoneum. And remember, the best X-ray for pneumoperitoneum is chest X-ray erect. If the patient cannot stand erect, then you go for left lateral decubitus with the horizontal beam. Okay, you will do left lateral decubitus with a horizontal beam, right? And what is this sign here that you are seeing here in a patient of pneumoperitoneum? Supine X-ray karo, air pura upar aa jayega like a football. So what do you see here is, this is the football sign. Okay, what do you see here is football sign, suggestive of massive pneumoperitoneum. Okay, this is suggestive of massive pneumoperitoneum. Next one, what do you see in this image here? Look at this chest radiograph. So what do we see here is all this jet black appearance without any vessels, and you are seeing the visceral pleural line of the lung very well, right? You see the lung markings here in this lung, but this is absolutely jet black without any vascular markings. Okay, this is jet black without any vascular markings. This is pneumothorax, and this one here is the collapsed lung. Okay, the lung which has collapsed. So this is pneumothorax. Okay, remember pneumothorax, clinically they will give you hyper resonant note on percussion, and the breath sounds are decreased. Remember, all pneumoperitoneum do not require needle puncture. Only if it is tension pneumothorax, that means the patient is hemodynamically unstable, then you will go for needle puncture. Okay, needle puncture and then ICD. That's what the management will be. And what sign do you see on M mode of ultrasound in pneumothorax? Remember this barcode sign. Okay, barcode sign or stratosphere sign, also lung point sign. Okay, barcode, stratosphere or lung point. Next one here, what is this? CT or MRI? Just outside this brain ka outline, the brain ka cortex, you see the black area. Do not focus on this white area. You see this black area. This is the black bone. So remember, this is MRI. This is not CT. And on MRI, when you see this black dots, right, with this black vessels also, this is SWI, susceptibility weighted imaging, which is the most sensitive MRI sequence for hemorrhage, It also helps to pick calcification on MRI. Okay, so SWI for hemorrhage or calcification. So when in a patient of trauma, you are given this image with the multiple, these are the tiny petechial hemorrhages, tiny hemorrhages. This is a case of diffuse axonal injury. Remember, it shows this petechial hemorrhages. Classically, the patient will have poor GCS. If you do the CT scan, majority of the cases, the CT scan is normal, right? So therefore, the investigation of choice here is MRI. Even in that, SWI to look for this petechial hemorrhages. Okay, clear with everyone? Going to next one, the CNS hemorrhages. All these images that you see here, this is the white bone, white bone, white bone, white bone. So all of these are CT scan. Remember, CT scan is the investigation of choice for acute hemorrhage. For chronic hemorrhage, it is MRI, SWI, but for acute hemorrhage, it is CT. Now, when on CT, you see this hemorrhage. How do I know this is hemorrhage, acute or chronic? Because this is white. White in radiology, remember, is called as hyper. Now, because this is on CT, this is called as hyperdense. It depends on the density. So, hyperdense or non-contrast CT either is bone, like you can see this bone calcification, or acute hemorrhage, right? So, that's how you know that this is acute hemorrhage because it is high density, hyperdense. Because it has a lot of fresh RBCs, fresh cells, that is why it is hyperdense. With age, what happens is the RBC lyses and the density decreases. It becomes dark. So, like you see this one, this is acute hemorrhage, but this is chronic hemorrhage. Why? Because this is appearing dark. So, dark, chronic hemorrhage, white, bright, acute hemorrhage. Okay. So, when you see the hemorrhage which is idly shaped, remember this is EDH. Okay, the biconvex shape, lentiform shape. Why? Because it does not cross the sutures. When you see the hemorrhage which is crossing the sutures, occupying the entire hemisphere, this is SDH. This is also SDH. This is acute, this is chronic. Okay, that's the difference in between the two. Going to next one, what do you see here is, this is the white blood. Remember, acute hemorrhage is white. White blood that you see here in the CSF spaces. CSF is present in subarachnoid space. So, subarachnoid CSF has been replaced by blood. This is subarachnoid hemorrhage. You see the star of death appearance, which might not be present in all the cases. This is the blood in the Sylvian fissure. This is subarachnoid hemorrhage. Most common cause is trauma. Next is Biliary aneurysm rupture. The patient presents with thunderclap headache. Remember, the subarachnoid hemorrhage can also lead to neck rigidity like meningitis, but there will be no fever here. Okay. So, this is subarachnoid hemorrhage. The first investigation you do here is non-contrast CT. After that, to look for where is the aneurysm, then you do the CT or MR angio. Okay. Then you will do a angiography to look for the aneurysm. First is non-contrast CT. Next one, this is the white acute hemorrhage in the parenchyma, in the area of the basal ganglia. So, this is intraparenchymal hemorrhage, the most common cause of which is hypertension. And even in hypertension, the small lenticulostriate arteries, that is lentiform nucleus striatum की branches वो break होती है. So, remember, the most common site of hypertensive hemorrhage is putamen. Okay, the most common site is putamen. Right? Can someone tell me what is this structure here anatomically? What is this structure here, guys? Now think logically. Now when you know what is black, what is white on CT, you will be able to identify this. You know that this is anteriorly present, black, jet black. This is frontal sinus. Okay, this is the frontal sinus. Front mein hai, this is the frontal sinus. Very good. Going to next one, the respiratory pathologies, some pleural pathologies that we see here, very frequently asked. When you see the concavity, the meniscus sign along with the angle blunting, right, the CP angle blunting, remember this is pleural effusion. Pleural effusion, remember, shows this Ellis curve. Okay, it shows this Ellis curve. And remember, investigation of choice for any fluid containing pathology is ultrasound. Okay, the most sensitive investigation for fluid is ultrasound. So, when you want to see minimal pleural effusion, ultrasound is going to be the best. Okay, so this is pleural effusion. Next one, if you see that the fluid layer is horizontal. Remember, horizontal, H for H, this is hydropneumothorax. Okay, there is blunting, but the layer is horizontal. Wherever there is air and fluid present together, it gives a horizontal level. Okay, this is hydropneumothorax. Okay. Next one, this is the collapsed lung with the visceral pleural line, and this is the black pneumothorax. So this is pneumothorax. Okay, this is pneumothorax, collapsed lung. Okay, what next one? Guys, tell me, what do you think is going to be the diagnosis here? Let's see who gets this right. What do you think is the diagnosis in the next one? Yes. Very good. Amazing. So that is asbestosis, because what do you see here? Remember again the concept that white is calcification here on X-ray. So this is a calcified pleural plaque. All these which you see here irregular, these white that you see here, these are the calcified pleural plaques. So very important, calcified pleural plaques. Okay, the calcified pleural plaques, this is seen in asbestosis. Remember the pleural plaques, pleura is mesothelium, that is what gives rise to mesothelioma in asbestosis. And also remember the mnemonic mesothelioma, calcified, calretinine. What is the tumor marker here? Calretinine. This is the most specific but not the most common. Most common is still bronchogenic carcinoma. And the calcified pleural plaques can give the irregular leaf shape here, which is called as holly leaf sign. Okay, this is also called as holly leaf sign. And remember in asbestosis, shipyard worker, that is going to be the most common occupational history given. Now going to the concept of when do you use what investigation, how do you decide when you are asked that what is the investigation that you will do in this patient. So remember that if the pathology is fluid containing, like for example pleural effusion, then for that case ultrasound is going to be investigation of choice, and on ultrasound the fluid appears black. If it's a air containing, air is best seen on CT and it appears jet black. Okay, and it appears jet black. Again for calcification C for C, it is going to be CT. Bone cortex C for C, it is going to be CT. Okay, so tell me that for which bone tumor is CT the investigation of choice and not MRI like the rest of the bone tumors? कौन सा बोन ट्यूमर है जो कॉर्टेक्स पे होता है, बोन के अंदर मैरो में नहीं होता है? It is based on the cortex. It presents with the cortical thickening and it has a central nidus. I'm giving you a clue there. The central nidus is present. Right? That is going to be O. O के अंदर O. Cortical thickening के अंदर nidus. That is going to be OO. That is osteoid osteoma. Remember for that we do radio frequency ablation. ठीक है, उसके लिए करते हैं radio frequency ablation. Treatment में. ठीक है, that's a treatment. For soft tissues, it is MRI. Remember in soft tissues comes the nerves, muscles, ligaments, even cartilage. All of this comes in soft tissues. So when you want to see nerves, which lung tumor invades the brachial plexus? The lung apex tumor, that is the Pancoast tumor. So for that, MRI. Ligament, ACL tear देखना है, meniscal tear देखना है, cartilage, तो आप करोगे MRI. ठीक है? बोन मैरो देखना है, जैसे बोन मैरो इडिमा, बोन मैरो का इन्फेक्शन इन्फ्लेमेशन, दैट इज ऑस्टियोमाइलाइटिस, avascular necrosis, or even a stress fracture which might be missed on X-ray or CT, you would do MRI there, okay, to look for the bone marrow edema. Okay, acute hemorrhage we said is non-contrast CT and it appears white, hyperdense. For chronic hemorrhage it is MRI. SWI, it shows the black areas, the areas of blooming. Okay, those are called the areas of blooming. Okay, and acute cholecystitis, when they give you a patient with acute right hypochondriac pain, vomiting is there, what sign is positive? Murphy sign positive. So that in that case, what will you do is ultrasound. Logically thinking, how will you see the gallbladder in acute cholecystitis? Same. Any acute inflammation, the organ will be bulky. So you will have over-distended gallbladder. Acute inflammation has fluid around it. So there will be peri-GB fluid which will be present. All these features will be given, right? So over-distended gallbladder with surrounding fluid, that's going to be acute cholecystitis. Next one, now identifying the investigations. Important. Tell me whether this is a CT or this is a MRI. What do you think, guys? This is CT or this is MRI? Yes, yes, Palak. In chronic cholecystitis, it is contracted gallbladder, right? Yeah, so you are asked question on this. So all you have to do is look at the bone lining, the bone cortex. Do not look at bone ke andar. Bone ke andar, if you see, this is black, but bone ka lining, if you see, it is white. So this is the bone cortex which is white. Okay, this is the bone cortex which is white, and that is why this is a CT scan. Okay, you have to look at the bone cortex, not at the bone marrow. Can someone tell me why the inner aspect of the bone is appearing black here? Why is the inner area of the bone black here? Why is this black on CT? See, because bone marrow can be fatty marrow or cellular marrow. If you see the marrow dark on CT, this is the fat containing marrow. Remember, fat is dark on CT because fat density is less than water. Okay, fat and air, they are less dense than water, they appear dark and they have a negative HU value. Okay, so they appear dark. So this is fat containing marrow. Absolutely right. Going to next one, all these three images, the black bone, black bone, black bone, this is MRI. Remember in MRI, how to identify sequence? T2 is World War II, WW2. What is the WW here? Water, white is T2. Okay, water, white is T2. So WW2, water, white is T2. That is what we need to know here. Next one is T1. Remember T1, first year subject is anatomy. So in T1, the anatomy is followed. White matter is white. Grey matter is grey. So the anatomical name is followed. White matter will appear white. Grey matter will appear grey. Grey matter is the cortex, the outer lining. So the grey matter, this ribbon like thing, this is the grey. और उसके अंदर जो दिख रहा है ये जैसे कॉपस कैलोजम है ये व्हाइट मैटर है, इंटरनल कैप्सूल ये व्हाइट मैटर है. So the white matter appears white. So if the white matter appears white, this is a T1 weighted MRI. And if you see that it's all black, the water is also black, the white matter is also black, this is going to be flare. In T2, the water, that is the CSF, appears white. Like you see here, the ventricle, the sulcal space ka CSF is appearing white. This is T2 weighted MRI. Okay. So remember T2, T1 and flare. That is how you identify. Next one, what investigation is this? Where you see the stomach plus you see all the small bowel loops. This is going to be BMFT, barium meal, which is followed through in the small intestine. And these bowel loops that you see here, which have the feathery appearance in the left upper quadrant, this is going to be jejunum. Okay, jejunum has feathery appearance due to the presence of lot of volvulae conniventis. Okay, volvulae conniventis. Okay, right. And very, very important, has been asked in the recent FMGE exam and previously also. The white bone is CT, but this is not a routine CT, black and white. You see the orange areas. So when you see a orange colored CT like this, an orange colored CT is a PET CT. PET plus CT combined, which is an example of hybrid or fusion imaging. Out of that, remember that PET is an example of functional imaging. Because whatever comes under nuclear medicine, PET is something that we, like the radiologists, do not do it. It is done by nuclear medicine people, right? So nuclear medicine is functional imaging. Radiology is more of anatomical imaging. So this is a functional imaging, nuclear medicine. And remember that in PET, what radioisotope do we use in PET scan most common? It is FDG, Out of that F, that is 18F, is the radioisotope. Why do we use 18F? Because it is positron emitter. What is the half-life of this 18F? Around 2 hours. Remember, diagnostic isotopes, generally the half-life is in hours. So 110 minutes, around 2 hours. Okay. And what is FDG? Fluorodeoxyglucose. Deoxyglucose because it is dependent on the Warburg effect. PET scan is generally done for cancer staging. So the cancer cells take up more glucose. So you use glucose to pick up those cancer cells. So remember that F is bound to deoxyglucose. So FDG PET is the most common PET which is done. Okay. Is this clear with everyone? Does PET scan have radiation exposure? Yes. Why? Because you are using a radioisotope. It has a radiation exposure. All nuclear medicine scans have radiation exposure. Okay. Right. Going to the next one, some more investigations here. What do you see here is, this is the endoscope, this is the CBD, and this is the pancreatic duct. So with the endoscope, this becomes ERCP. Okay, with the endoscope, this becomes ERCP. When you see the CBD and pancreatic duct without any endoscope, no white bone, this is going to be MRCP. So comparing the ERCP and MRCP, remember ERCP you can see is the X-ray in the background. It's a contrast X-ray, it's a dye study. So this is a contrast X-ray, so the radiation is present. MRCP is nothing but MRI. MRI has no radiation. So MRCP has no radiation. What sequence will you use for MRCP? T1 or T2? Think logically. If you want the water to appear white, water white is on T2. So remember, MRCP is a T2 weighted. This is investigation of choice. And this is the gold standard. Why? Because this is invasive. ERCP is invasive. So you don't do it like as a first investigation. First you do MRCP, right? And then you want to treat, therapeutic is ERCP and not MRCP. Okay. The advantage of MRCP is that you can do that without any contrast also. Just the T2 weighted MRI will give you the white bile duct. Okay. So without any contrast, so it can be done in patients with renal failure also. Okay. MRCP and HIDA, how to identify? See, HIDA is a nuclear scan. So you will see that black color ka image. Okay. And in the HIDA, you will see that bile duct, jisme se if it is going into the duodenum, that is what you would see. You are not seeing the pancreatic duct in HIDA. HIDA is for biliary tract only. MRCP, you also have this pancreatic duct which you are seeing. Okay. Next one, what is this investigation where you see this waveform? This is a Doppler. Okay, remember Doppler is the screening investigation or the first investigation for peripheral vascular disease. So when they give you a patient with intermittent claudication, right, peripheral vessels ka kuch soch rahe ho, the first thing in peripheral vessels we do is Doppler. Okay, so Doppler karte hain peripheral ke liye. Yeah, MRCP is non-invasive because you are just doing a MRI scan and nothing else. ERCP is invasive, you are putting an endoscope. Okay. Does Doppler have radiation exposure? No, because it is just ultrasound. So remember, there is no radiation in Doppler. Okay, there is no radiation in Doppler. Next one, what investigation is this? This is a vessel. Which vessel is this? The tortuous one, internal carotid artery. So when the vessel appears black, the angiography where the vessel appears black, it's always a DSA. Remember this point, digital subtraction angiography. Whenever you see a black vessel, it's always a DSA. CT angio, MR angio never will have a black vessel. Digital subtraction angiography, how do you give the contrast? Is not intravenous. You give the contrast intra-arterial. You go into the artery, right? And that is why this is an invasive angiography. So is it going to be investigation of choice? No, it is generally gold standard. It is therapeutic also, right? So you reserve it for the last. Okay, this is DSA. Next one, coming to some nuclear scans, parathyroid adenoma is so important, where they give you the history of stones, bones, moans and groans, hyperparathyroidism. Okay, so remember it is Cysta MEB scan. In the exam, they can also give you the MEB scan, Cysta MEB, which is picked up by parathyroid. And remember that SPECT is always better than scintigraphy. Okay, it is like CT scan and X-ray. What is better? What has better resolution? CT scan. So similarly, SPECT has a better resolution than CINTI. If you have both in the options, you go for SPECT. Meckel's diverticulum, MEC is TEC. So what do we use for Meckel's diverticulum is pertechnate. Technetium 99, pertechnate. Why? Because this is picked up by the ectopic gastric mucosa in the Meckel's diverticulum. So pertechnate is picked up by that, and that's how you identify Meckel's diverticulum. Pheochromocytoma, catecholamines जो होते हैं, they come from tyrosine, dopamine, right? So remember, you do what PET here? DOPA PET, or what nuclear scan? MIBG scan. Because this MIBG is taken up during catecholamine synthesis. So you will pick that up wherever the catecholamine is getting synthesized. For ejection fraction, that means which is a function of the left ventricle, you do a scan which is MUGA, multiple gated acquisition. Now coming to the iodine isotopes. Iodine isotopes, remember, used for diagnostic radioactive iodine uptake scan. The ideal is iodine 123 and not iodine 131. Though in India we use 131 also, but ideal is 123. Why 123 is ideal? Logically thinking, because a diagnostic isotope should have the half-life in hours. So this is 13 hours ka half-life hai, that is why it is better. But the one which is used for thyroid ablation, that means for treatment, that has the half-life in days, right? So remember, this is iodine 131, which has the half-life in days, which is 8 days. And iodine 131 therapeutic effect is due to what rays? Beta rays, not gamma rays or alpha rays. It is because of the beta rays, right? But remember that iodine 131 is not a pure beta emitter. It emits beta plus gamma. Out of that, beta rays is what is therapeutic. Used as brachytherapy implant, like commonly used in prostate cancer, which iodine isotope? Iodine 125. You put it at the seeds as the implants for prostate cancer. Iodine 125, 12 into 5. Remember, it has a half-life of 60 days. Okay, half-life of 60 days. Okay. So these are the important nuclear scans. One of the recent FMGE July exam had a question on PSMA scan. Remember, PSMA prostate specific membrane antigen hai. This is used for prostate. Okay, this is prostate specific. So PSMA is for prostate. Okay, PSMA is for prostate. Okay. Going to next one, radiosensitivity, which is the most radiosensitive tissue, the one which is always dividing, that is bone marrow. And which is the most resistant, not dividing, not regenerating, that is the neurons, the nerves. Most radiosensitive pelvic organ. If in the exam you have questioned that which organ is most sensitive, then it is gonads. Okay. So most sensitive is gonads and most resistant pelvic organ is vagina. Tumors which are most sensitive is Wells and most resistant is Morph. What is Wells and what is Morph? What does Wells stand for? Wings tumor, Ewing's tumor, Ewing sarcoma, then you have lymphoma, multiple myeloma and seminoma. The counterpart of seminoma, which ovarian tumor is radiosensitive, is dysgerminoma. Okay, dysgerminoma. Then you have Morph. What does Morph stand for? Morph stands for melanoma, right? Then comes osteosarcoma, melanoma, osteosarcoma, RCC, pancreas and HCC. Okay, RCC, pancreas and HCC. Cell cycle phase, most sensitive is when the cell is dividing, mitosis, M phase. It is G2, M, and the most resistant is the S phase. Okay, the most resistant is the S phase. And remember, there is this, the inverse square law has been asked in your last year NEET PG exam. What is the inverse square law? Inverse square law tells you that if this is the radiation source, one patient point A, one patient point B. Logically thinking, the more away the patient, the radiation received is going to be less. How much less? That is what it tells you, that if this distance is 1x and this distance is 2x, you double the distance, it is going to be inverse square radiation. That means it is going to be 1 by 4. You triple the distance, the radiation is going to be 1 by 9. Okay, so remember that it is inverse square law which tells you the relation of radiation and the distance. Okay, the radiation and the distance. Okay? Intensity inverse to distance square, not just the distance, it is distance square. Okay. Right, going to next one, few other pathology, the images that I wanted to share, white out hemithorax. So remember that when I say white, either it is increased density, like that appears white, or in the lungs there is no air, no black air, and that is why it appears white. So remember, consolidation, density increasing, collapse, no air, or even pleural effusion will appear as white out. Pneumothorax will appear as black. How do we divide the three causes of whiteout is depending on the tracheal shift. If the tracheal shift is happening to the opposite side, like you see here, then it is pleural effusion. If the tracheal shift is happening to the same side, like the whiteout, then it is collapse, because collapse will pull the structures. If there is no tracheal shift, then it is consolidation. Remember, consolidation, there is no volume change. Just that air is replaced by something else. So there is no shift. Also, consolidation is confirmed by the presence of this sign, which is called as this air bronchogram sign. Okay, what sign is this called as? Air bronchogram sign. What is the air bronchogram? The white lung gives a good contrast to the black air-filled bronchi. This is air bronchogram sign, which is going to see, you are going to see that in intraparenchymal pathologies, not in extraparenchymal. Will you see in pleural effusion? No, because there are no bronchi outside the lungs in the pleura. So no bronchogram you are seeing there. Will you see in mediastinal mass? No, because it is outside the lungs. Okay. So remember, it is not seen in pleural effusion or mediastinal mass. Very, very important. You do not see it in extraparenchymal. It is a sign of intraparenchymal pathology. Okay. Right. I am coming to pneumonectomy, Aman. Tell me that pneumonectomy is going to be white out or black out. When I say pneumonectomy, that means the lung is removed, and what does that mean is there is no air now. So even pneumonectomy is going to be white out. Okay, even pneumonectomy is going to be white out because now it's like a collapse. There is no lung, no volume. Okay. And the next one, tell me that how will the lung appear? If suppose a patient has undergone left mastectomy, in that case, how will the left lung appear as compared to right lung? More black or more white? If the patient has undergone left mastectomy, so the left lung will be more black or more white? When I say that the mastectomy has been done, that means the breast overlying has been removed. So the overall density of that side of the chest wall has decreased. So the lung will appear more black. Why? Because the density is decreased. Okay, the density is decreased. Same concept in pollen syndrome, where there is pectoralis major is absent. Okay. Next one, coming to some anatomy, radio anatomy identification. This is MRI with the black bone, T2 weighted, CSF white, and where you have this Mickey Mouse shape. Okay, this Mickey Mouse shape, MI, Mickey MI, this is going to be midbrain. Heart shape in the midline, Mickey Mouse shape, this is going to be midbrain. Next one, again this is MRI with the black bone, the white matter is white, this is T1 weighted MRI, and look at this one, in the midline is the third ventricle, TT के बाजू में आता है TT, that is this is going to be thalamus. Okay, this is thalamus. Frontal horn के बाजू में ये आता है caudate. फिर आता है ये caudothalamic groove, यहाँ पे आ रहा है internal capsule, and then you have the globus pallidus and the putamen that forms the lentiform, and lateral to that this one is the insula. Okay, this is insula. Cadaveric image section for this is also important. Okay. Next one, this is the sagittal MRI image where you see that this is midbrain, pons, medulla going into the spinal cord through this foramen magnum. This is cerebellum. This is the fourth ventricle that you see here. Above that is the aqueduct of Sylvius going into the third ventricle. Then there is this second, that is the lateral ventricle. Okay. So you will have the foramen of Monro present here. This is the corpus callosum. And this white matter that you see here beneath the corpus callosum, this is the fornix. Okay, what is this? This is the fornix here. Okay, और midbrain के आगे ये जो छोटा सा structure दिख रहा है ये है mammillary body. Pineal gland कहाँ होता है? Pineal gland यहाँ होता है. ठीक है, थर्ड वेंट्रिकल के पीछे होता है पीनियल ग्लैंड, स्प्लेनियम ऑफ कॉर्पस कैलोजम के नीचे. And this one here, this is the pituitary gland. This is the stalk of the pituitary, and this black here is the sphenoid sinus. You go transsphenoidal for pituitary mass. Okay, transsphenoidal surgery. So this is important anatomy that you should know here. Next one, this we have already seen. What is this? Pulmonary artery, SAP. Okay, this is pulmonary artery. What bowel loops are these? Because you see this complete rings, volvulae, coniventous. This is going to be jejunum. Jejunum has this complete rings. Colon has hostrations incomplete. These are through and through complete rings, jejunum. This is a CT scan. You already know that this one here, this is the aorta. To the right of the aorta, this is IVC. And in front of IVC, this is the portal vein. This is the pancreas here going from right to left. And behind the pancreas, you have this splenic vein. The splenic vessels behind the pancreas, right? One of you was asking, where is the superior mesenteric artery? ये जो दिख रही है यहाँ पे, this is the superior mesenteric artery. Coming from the aorta, this is the superior mesenteric artery. And what is this? Behind the IVC, this Y-shaped structure, this is the adrenal. The right adrenal gland and this is the left adrenal gland. Okay, छोटे से ऐसे V-shape, Y-shape दिखता है. This is the adrenal. And look at this one now. This gray color structure here is the gallbladder. Look at how gallbladder is superficially located, right? Anterior, it is not posterior. IVC जैसा नहीं है पीछे. ठीक है, clear with everyone? And this is the stomach because it is containing the air, right? This entire thing here, this is the stomach containing the air. The solids organ here, this is the spleen. This is the left kidney. You are not seeing the right kidney because the right kidney is lower down. Okay? The right kidney is lower down. Right, going to the next one. This also has been asked in the exam. This is the heart के 4 chambers. Sternum के just पीछे आता है retrosternal anterior most right ventricle और vertebra के just आगे posterior most आता है RV का उल्टा LA left atrium posterior most. This is the midline of the heart. So to your right, these are the left sided chambers. Left atrium, left ventricle, right ventricle, right atrium. Draining into this left atrium, this is the pulmonary vein. Okay, that's the pulmonary vein. Okay, clear with everyone? And this is the aorta here. Okay? Next one. Look at this X-ray elbow. Posterior, this is the olecranon here that you are seeing. This is the radius head. Okay, this is the radius head. And remember, head के ऊपर आता है cap. This is capitulum. Because this is radius head, so this epicondyle will be the lateral epicondyle, this epicondyle will be the medial epicondyle. Okay, that's how you'll identify lateral and medial. Radius के side lateral, ulna के side medial. ठीक है? Next one, this is a pubic symphysis. What kind of joint? Secondary cartilaginous joint. This is obturator foramen, greater trochanter, lesser trochanter. Lesser trochanter LL, this is going to be iliopsoas coming in here. Okay? And this is the SI joint involved in ankylosing spondylitis. Next one, coming to tarsal bones, forming the ankle joint with the tibia. TT, this becomes the talus. Forming the heel, this is the calcaneum. Okay, and just in front of a talus is the navicular. Okay, so this is the TCN joint, which is a ball and socket type of joint. Okay, so this is navicular, talus and calcaneum. Look at this image. हील वाला कैल्केनियम, टीबिया के साइड में टीटी, टीबिया के साइड में टैलस, टैलस के आगे नाविक्यूलर, सी यहाँ पे कैल्केनियम के आगे जो सी है, दिस इज गोइंग टू बी क्यूबॉइड हियर. ओके, दैट्स अ क्यूबॉइड. जो फिफ्थ मेटाटार्सल के यहाँ आता है वो होता है क्यूबॉइड. ओके, दैट्स अ क्यूबॉइड ऑन द लैटरल साइड. ठीक है, क्लियर विथ एवरीवन? Going to next one, very very important. This has been asked in previous exam. What do you think? Which lobar pathology is this? Which lobar pathology is this? Yes. Very good. This is right middle lobe. It's a spotter image. When you see this wedge shape opacity overlying the heart on a lateral chest x-ray, this is right middle lobe. Why right middle lobe? Because it is present in between the two fissures of the right lung, the horizontal fissure and the oblique fissure. In दोनों के बीच में जो आता है, that is the middle lobe. Okay, so this is middle lobe pathology. How do I identify here this is middle lobe or lower lobe? If I see that the right heart border is obscured, I cannot see the right heart border very well, then it is right middle lobe pathology, which is silhouetting the right heart border, silhouetting the right heart border. If the pathology is silhouetting, that is hiding the left heart border, then you do not have left middle lobe. Okay, this is going to be lingular. Okay, this is lingular pathology. Okay, that is lingular pathology. Look at this one. What is this image showing? You can see this white calcification surrounding the heart. So this is calcification surrounding the heart, calcific constrictive pericarditis. What pattern do you see in JVP? What pattern do you see in JVP for calcific constrictive pericarditis? Remember MCP, it shows MCP, that is the M pattern. Okay, that is the M pattern. A deep or prominent Y descent is what you see here. X and Y both are present. X and Y both are present, but the Y is prominent. Okay, the Y is prominent, aggravated Y. And remember for constrictive pericarditis, हमने देखा है mnemonic KK. What are the two KKs present? This has been asked in recent FMGE also. K is the Kussmaul's sign, not the Kussmaul's breathing, and the pericardial knock. Okay, Kussmaul's and pericardial knock both is present here. Next one, this is the boot shape heart, classically seen with boot is TOF. Okay, bot is TOF. So remember it is tetralogy of Fallot. Why do you see in TOF? Is because of right ventricular hypertrophy, pulmonary stenosis. This is the figure of 8 shape heart, classically seen. ये है heart और उसके ऊपर supracardiac TAPVC. Figure of 8 snowman heart. Remember snow comes from ऊपर से, supra. So snowman is supracardiac TAPVC. Okay, that is supracardiac TAPVC, type 1 TAPVC. TAPVC has plethoric lung fields or oligamic lung fields. Remember cyanotic heart disease, plethoric wale hai, except for TOF, tricuspid atresia, they have oligamic. Okay, this is plethoric. Okay, plethora is present, not oligamia. TAPVC is plethora. Next one, few important PYQ images here. This is a CT scan with the white vertebra. Okay, and this is the MRI with the black bone. So this image is showing MRI. This image is showing CT. And in both, look at both the kidneys showing this grey color. This is polycystic kidney disease. Similarly here on MRI, this white is not calcification, is fluid. This is polycystic kidney disease on MRI. Okay. So remember MRI hai ki CT, and that is how you'll identify the polycyst there. What is this image showing? These are the two kidneys fused in the midline. This is horseshoe kidney, which is associated with Turner's. Okay, horseshoe kidney, Turner se associated hai. Look at this kidney here. What is abnormal in this kidney here? This kidney, normal, grey color appear kar rahi hai aise. This is a completely white kidney with this lobulated appearance. The white lobulated appearance, this is putty kidney, which is seen in TB. Okay, this is putty kidney seen in TB. Similarly here, this is the white on X-ray. This is the putty kidney seen in TB. You see this on X-ray and CT, plain X-ray, plain CT, right? And remember in TB, the history given is sterile pyuria. What history is given is sterile pyuria. Correct. Look at this one. What investigation is this? IVP, where you see the kidney, ureter, the image has been cut. You will also see the bladder. You don't see the urethra but on the left side, you can see that even after 20 minutes also, you are just seeing the left kidney. You are not seeing the left ureter. Why? Because there is an obstruction here. Okay, so this is a PUJ obstruction, a left PUJ obstruction with hydronephrosis. Will there be hydroureter here? No. PUJ obstruction will cause hydronephrosis, not hydroureter. The ureter is not seen. Okay, the ureter is not seen. Versus, can someone tell me what investigation is this? Is this a IVP, guys? Is this a IVP? Remember, that is not a Staghorn calculus. Staghorn calculus you see on a plain X-ray, not on a IVP. It will not appear white on IVP. It is a X-ray पे जहाँ वो white दिखेगा, plain X-ray. Okay, your first question, identify the investigation. IVP, RGP, RGU, MCU. What investigation is this? See, if it would have been a IVP, you would just see the kidney, ureter and bladder. Here you are seeing the urethra also. That is why your IVP and RGP is out. Okay. So, this is urethra seen and therefore, this is not IVP. Okay. Now, the urethra is seen. It could be a retrograde urethrogram or it could be a micturating cystourethrogram. Here you are seeing the entirely filled bladder, distended bladder. So, this is a micturating cystourethrogram. RGU, you go into the urethra. MCU, the bladder contrast comes into the urethra. Okay. Plus, what is abnormal here? When I say it's a micturating cystourethro, so you should see the cysto and the urethro. You should not see the ureter and the kidney. Right. So, remember in MCU, if the ureter or kidney is seen, it is abnormal and it is suggestive of when the patient is micturating, bladder contracting, the contrast is going up into the ureter and the kidney. So, that is suggestive of vesicoureteric reflux. Okay. So, that is vesicoureteric reflux. So, remember investigation of choice for vesicoureteric reflux is MCU. Because when the patient is micturating, you will see the contrast going up. And the classical history in VUR that they will give you is history of a child with recurrent UTI. History of a child with recurrent UTI. Why this is not RGU? Because सबसे पहले RGU में never you will see the ureter or kidney anytime. Second, in RGU, the bladder you will see just some contrast, not a completely distended bladder like this. Okay, right. So, remember MCU is the investigation of choice for VUR and also for posterior urethral valve. Okay, and when you want to see the scarring in the VUR, right, chronic VUR can lead to the kidney का scarring. अगर आपको स्पेसिफिकली ये क्वेश्चन पूछा जाए कि स्कारिंग के लिए आप कौन सा इन्वेस्टिगेशन करोगे, तो स्कारिंग के लिए हम करते हैं न्यूक्लियर स्कैन विच इज DMSA. DMSA, remember it as S for scar. Okay, so S for scar, DMSA is done to look for the scarring. Okay, clear with everyone? So, very logical, no? Study bistro की nephrocalcinosis, calcinosis है calcification, white दिखेगा. यहाँ पे जो आप cyst देख रहे हो ये ग्रे दिखेंगे, calcinosis white दिखेगा. यहाँ पे ये जो किडनी में white दिख रहा है ये contrast है, ठीक है, ये calcification नहीं है. MRI में जो white दिख रहा है ये पानी है, ये calcification नहीं है. Okay, right. Going to next one, what are we measuring here? What scan is this? NT scan, which is also called NBNT scan because you look for the nasal bone. NT scan is done at 11 to 13 weeks. It's a first trimester screening for Downs. NT more than 3 millimeters is abnormal. You need to confirm it by karyotyping. Do not go for MTP directly. Do karyotyping, combined screening. Okay, that is important. Next one, when you see the cystic appearance in the uterus, no fetal parts, this is snowstorm appearance of complete molar pregnancy. Okay, snowstorm appearance of complete molar pregnancy. Next one, when you see the follicles in the periphery of the ovary, the string of pearls or the necklace sign. Remember, the string of pearls or the necklace sign is PCOS. Why do you see the follicles in the periphery? Because in the center the stroma has increased central stroma. Why has the central stroma increased? Because of the androgens. The central stroma is androgen dependent. In PCOS there is increased androgen hirsutism. So that is why you get central stroma thickened. And remember, that pushes the follicles to the periphery. All the follicles are 2 to 9 millimeters. No follicle more than 9 millimeters. There is no dominant follicle. Okay, no dominant follicle is what you would see here. Okay? Chalo. Next one, what investigation is this? This is X-ray with the contrast here. This is HSD, hysterosalpingogram. Because it's a X-ray, does it have radiation? Yes. When will you do HSD? Day 9 around. Not after day 10, day 14, day 16 क्योंकि pregnancy का chance है radiation वाला नहीं करेंगे. So initial days में नहीं करेंगे, menstruation है, so day 9 is the best. And when you see this banana shaped uterus like this going on one side, this banana uterus is a unicornuate uterus. Okay, this banana uterus is a unicornuate uterus. Okay. And but remember that HSD is not the investigation for uterine anomalies. For anomalies, first you do 3D ultrasound, then you have MRI, which is even better, and then you have gold standard, which is hysteroscopy plus laparoscopy. Why hysteroscopy, laparoscopy? Hystero mein you see the endometrium, lapro mein you see the bahar ka surface. For uterine anomaly, you have to see both inner and outer. Okay. So the gold standard is hysteroscopy plus laparoscopy. Right. Going to next one, if this is a thyroid scan, what do you think is this thyroid scan showing? Black uptake is a hot spot. Okay, so on nuclear scan, remember black is hot. This is a thyroid scan. So diffuse hot spot, that is diffuse increased uptake. Diffuse increased uptake in thyroid is seen with Graves, thyrotoxicosis, right? Thyroid is very hyperactive. Diffuse decreased, thyroid is burnout, no thyroid hormone synthesis happening. That is going to be in thyroiditis. Okay, that's going to be in thyroiditis where there will be diffuse decreased uptake. Next one, which of the following shows this graph? Is it a X-ray beam, a gamma ray, a proton, a neutron? What shows this graph? So this graph is showing a peak that you are seeing here. This is called as Bragg peak. Remember it as BR is seen with PR, that is proton. Proton shows a Bragg peak, which tells you that proton will give all its energy at this point, that is the tumor site, right? So proton ka advantage hai, it gives a very targeted treatment to the tumor, not affecting the surrounding tissues. That is the advantage of proton. Okay, Bragg peak effect. Next one, this is the hair on end appearance, crew cut appearance seen in hemolytic anemia. Okay, hair on end, crew cut appearance, hemolytic anemia, that is sickle cell anemia, thalassemia, G6PD उसमें दिखेगा. Because hemolytic anemia में क्या होता है कि hematopoiesis बढ़ जाएगा to compensate. So all this that you are seeing are the prominent trabeculae telling you that this bone is being employed for hematopoiesis, hair on end appearance. And the next one here where you see the femur. Okay, look at this femur which is bent. Fib is femur bent. Okay, remember it as fib, femur bent. So this is fibrous dysplasia. Fibrous dysplasia, which tells you that instead of the bone, osseous tissue, there is fibrous tissue which is less dense. Less dense means it will appear less white. So this area is appearing less white, this area is appearing less white because it is fibrous dysplasia. Okay, so remember that is called as what matrix? Gray matrix is called as ground glass matrix. Okay, ground glass matrix. And remember the syndrome associated with fibrous dysplasia, McCune-Albright syndrome, right, which has 3 P's: precocious puberty, polyostotic fibrous dysplasia, and pigmentation, that is caffeole spots. If you have fibrous dysplasia plus you have the, right, what do you have in Mazabrod syndrome? Plus you have the myxoma, right? If it is associated with myxoma, then that becomes Mazabrod syndrome. If it is the other 3P wala syndrome, then it is McCune-Albright syndrome. And this deformity of the femur, this is called as Shepherd-Crook deformity of the femur. This is Shepherd-Crook femur, Shepherd-Crook deformity of the femur. Okay. Right. So that is done. So at the end, I have given you the compilation of all the PYQs of radiology, NEET PG PYQs, and also the radiology FMG PYQs is what I have given you. You can quickly go through the list after this session and see for yourself what you remember, what you don't remember. So one point here, feline esophagus is seen in reflux esophagitis or also in eosinophilic esophagitis, where you see this prominent transverse folds in the esophagus. Okay, that is feline esophagus. And this one here, this is the aorta and this is the superior mesenteric artery. This is showing the SMA syndrome, right? The third part of duodenum getting obstructed leading to duodenal dilatation. SMA syndrome is superior mesenteric artery compressing. Okay. Remember, a female on OC pills will have hepatic adenoma. Vein of Galen malformation classically is going to be a neonate with heart failure. Vein of Galen malformation present in the brain, but it's a AV fistula. Hyperdynamic circulation leads to heart failure plus hydrocephalus. Whenever you have that history in a newborn, you should think of that. Okay. Bragg effect हमने अभी देखा, HSG unicornuate अभी देखा, SMA already देखा है. Craniopharyngioma versus pituitary adenoma, someone of you had asked. Remember, the difference is, if this is the pituitary adenoma comes from the pituitary itself, while craniopharyngioma is suprasellar. Okay, it comes from suprasellar and then it can go into that sella. But pituitary adenoma grows from the sella itself. So what will it cause is widening of the sella first. It will first cause the widening of the sella, and then if it is very big, then it will go out. So first it will cause the widening and then it will go out. So what will it form is figure of 8 appearance. So remember, it is pituitary adenoma which will show the figure of 8. Craniopharyngioma CCC, you will see it generally in a child. It will have calcification present, cystic areas present, all those will be present in craniopharyngioma. Okay. So that's the basic difference in between the two. ठीक है, तो ये पूरे मैंने आपको लिस्ट दी है. Just quickly go through the list so that you know that you remember all of this. Remember, for early infarct, DWI MRI is the best and not the CT. CT can be normal in early. TLD badge is used for personal monitoring. Every 3 months you monitor that. Okay. So all this अभी देखा हमने craniopharyngioma, cystic calcification CC, ये आपको पता होना चाहिए. Plethora TA PVC में है. So we have seen the majority of these already in the today's session. Cephalohematoma का याद रखना कि does not cross the midline, while caput crosses the midline. Cephalohematoma can show the calcification. Caput does not show the calcification. Okay. So that was about, yeah, lipid peak is tuberculosis. In MR spectroscopy, lipid peak is TB. ठीक है. CT of ARSA, let me see if I can show you from the image or directly here. ARSA CT, let me show you from here itself. I can show you the ARSA image. Right, so can you guys see this image here? So look at this image here because I have to mark this. Where did I put my pencil? Just a minute. Yeah. So what are you seeing in this case is, look at ARSA में क्या होगा कि जो aberrant right subclavian artery है, this is the arch of aorta and you are seeing an artery coming from the arch of aorta. It is going behind the trachea and the esophagus. Okay, it's going behind the trachea and the esophagus. So ARSA goes behind the esophagus, not in between the trachea or esophagus or in front of trachea. So that is why it causes that esophageal compression, dysphagia lusoria. I have discussed this. This is a INICET question. You can check that on Prep Ladder YouTube channel also, where I have discussed the INICET recall. I have shown you another image which was asked in INICET, right? So you can check that there as well. You can see the recent INICET recall and the recent FMGE exam recall also from the Prep Ladder YouTube channel, because those PYQs have not been included in the list also, right? So those two videos you can check from the Prep Ladder YouTube channel. See, bicornuate and didelphys you cannot differentiate on HSG, you have to do it on MRI. Okay? Bicornuate, remember that bicornuate, let me tell you this. जो bicornuate uterus है, bicornuate uterus and septate. These look similar on HSG because both of them will show the endometrium like this, endometrium which is separate. So in HSG you only see the endometrium. But when it is bicornuate, remember it is complete. मतलब अंदर और बाहर का surface भी complete bifid होगा. Septate में S for S you will see a smooth outer surface. Septate will have a smooth outer surface. Bicornuate will have complete, bifid completely. Okay, so that is how you will differentiate. Outer surface is what we have to see. Choline peak, Aarti Priyanka, remember logically, choline is present in the cell membrane. When you see a choline peak, it is telling you a high cell turnover is happening, high cell division. So it's a tumor, right? So remember in MR spectroscopy, choline is a tumor, brain tumor. Lipid peak is seen with TB. Lactate peak is with necrotic areas like toxoplasma वगैरह. ठीक है? On the basis of angle, Dheeraj, you can, but there is no definite angle where you can be very sure. It's a gray area. If definitely you see that the two cornu are very widely separated, it's definitely a bicornuate uterus. Okay. If you see the two cornu are very close together, small angle. Remember S for S again. Small angle, bicornuate BI, big angle. So big angle, bicornuate, small angle, septate. But how small? There's always a gray area and overlap, so you cannot be very confident on HSG for that. Okay? चलो, radiation units का एक video है मेरे channel पे. You can just search radiation units Dr. Nikita. I've done that with all the tricks. Okay, you can watch it at 2x and complete the radiation units for that. MRI, yes, can be done in pregnancy. There's no radiation in MRI, right? So you can do MRI in pregnancy. ठीक है? Liver segments on CT, ये मैंने कहीं cover किया है कि नहीं, I don't remember. Let me see again if I can cover that quickly for you guys, so that none of you are in that confusion before the exam. Liver segments CT, let me quickly check that. Alright, so let's try to see this image and the liver segments. First, let me give you this image for the liver segments. Remember, the portal vein bifurcation divides into upper and lower half. Then you have the middle hepatic vein which divides into right and left. And even in the right and left, you have this. So the upper half of the liver, remember it is 2, 4, 8, 7. Double karo 2, 4, 8, 7. फिर नीचे sequence से 3, 4, 5, 6. Remember 4A above, 4B below. A above, B below. ठीक है, ऐसे होते हैं liver segments. So this one which you see here, basically this is the line dividing. ठीक है, so this is the left lobe of the liver. This is the right lobe. So what does the left lobe has? 2, 3, 4. What does the right lobe have? 5, 6, 7, 8. Okay. Now look at this one. When you are seeing just the IVC and a part of the lung, that means the liver section is superior. So this is going to be 2, 4, 8, 7. When you will see the kidney coming in or the adrenal coming in, ये आप नीचे की तरफ आ रहे हो, as you come down, you are going to see 3, 4, 5, 6. ठीक है, जब आपको ये bifurcation दिख जाएगा, जब आप नीचे नीचे आते जाओगे, then that will become 3, 4, 5, 6. ठीक है, you will also see sometimes the kidney will be shown here. When the kidney is seen, you definitely know that it is below section. So then it is going to be 3, 4, 5, 6. अगर पीछे यहाँ पे lung दिखेगा, then it is going to be 2, 4, 8, 7. Okay, that is how you basically differentiate. Okay, so these are the segments. Right, done. Contrast का भी video है YouTube पे, check कर लेना contrast Dr. Nikita. So that will be there. MRCP पे no contrast is needed. Okay, you can do MRCP with contrast, but it's not essential because the T2 weighted image itself gives the contrast, the white appearance of the bile duct. Okay, right. So thank you so much everyone for joining in, and remember that you are almost there. You have come so near to your goal. So please do not undergo that burnout, that anxiety, that panic, that blackout and burnout, right? So that's very, very common in the last days. You will feel that you are not remembering anything. जो भी पढ़ा कुछ भी याद नहीं है. But trust me, you will remember that in the exam hall. है ना? So just keep studying, right? And please do some breathing exercises, some meditation, yoga nidra to keep yourself calm so that you do not panic out and you do not get stressed. And whatever said and done, remember at the last, it is just one exam. Many students ask me, what if, right, I don't clear this exam? So, to kya? So, right, it is like, to kya hi hoga? Even if you're not able to clear it, I know that I should not be saying that, but the thing is, if you remove that fear of, even if I don't get a very good result, it's absolutely fine, you will be fine, right? It's only the attachment to the result. It's like, बहुत important exam hai, बहुत important hai, aisa hai, वैसा hai. Then you start panicking out when you think about the results and when you start getting the fear of the results. When you are detached from the results, you will be very relaxed. And trust me, when you are relaxed, you perform better. So the best is detach yourself from the results. Just focus on giving your best. That's it, right? That is what you can do at the end of the day. Do not waste your time and energy in worrying and anxiety. At the end, it will not give you any results. Okay? Chalo. Thank you so much, everyone. Goodbye. Take care. Like I told you that I'm planning to do your like one shot or maximum in 2 sessions, the FMG recent exam questions, because there might be a lot of overlap of the FMG questions in your recent NEET PG also. We saw a lot of NEET PG questions coming as it is in the recent FMG exam. So that's why, to get that all at one place and to give you that one like quick revision of the FMG questions, I'll plan one session on YouTube. I'll update you about the same on the Telegram group as well. So please stay connected on Telegram. Thank you so much, everyone. And thank you so much. Take care. Keep studying, keep revising, keep med synapsing, and keep winning. Thank you.